Hello, everyone. My name is Otavio. He's Coelho-Filho. I'm Associate Professor of Cardiology at University of Campinas, São Paulo, Brazil, and one of the session editors at the Circulation Cardiovascular Imaging, responsible for cardiovascular imaging cases, and in conjunction with the two other section editors, Dr. Renee Bullock-Palmer and Ahmad Masri, I'm delighted to officially open the second webinar series entitled The Diagnostic Effectiveness of Nuclear, Molecular, and Multimodality Imaging Techniques. Multimodality imaging has become increasingly important in several conditions, including cardiomyopathies, ischemic heart disease, as well as congenital heart disease. In today's webinar session, we will have the opportunity to discuss in detail three remarkable cases selected by myself and by my two colleague editors, Renee and Ahmad. These cases highlight the crucial role and utility of novel multimodality imaging techniques in a series of clinical scenarios. Given the rapid progress in multimodality imaging, engaging in discussions with experts on this subject is both timely and highly beneficial, and I hope that everyone here enjoyed the discussions. We'll have the privilege to count on a very distinguished group of panelists. And here I would like to take extra time to formally acknowledge all panelists that were kind enough to find time in their busy schedule to be here today with us. The group of panelists for today's webinar includes Professor Jamieson Bourque, who is an Associate Professor of Medicine and Radiology at the University of Virginia, where he is also the Medical Director of Nuclear Cardiology, Echocardiography, and Stress Lab. He served as co-chair of the recent consensus statement of multimodality imaging in cardiac amyloidosis, and he is the treasurer of ASNC and the vice president-elect of the Society of Nuclear Medicine and Molecular Imaging. We will also have the privilege to count on Professor Angela Dispenzieri, who is a consultant in the Division of Hematology from the Department of Internal Medicine at the Mayo Clinic. She has joint appointments in the Division of Clinical Biochemistry and Immunology, and Dr. Dispenzieri holds also the academic rank of Professor of Medicine and Laboratory Medicine and Pathology at the Mayo Clinic College of Medicine. She also is recognized with the distinction of a named professorship, the Serene M. and Francis C. Darling Professorship. Dr. Dispenzieri currently chairs the Mayo Clinic Amyloid Interest Group. We also have Professor Inga Voges, who is a consultant pediatric in adult congenital heart disease at the University Hospital of Schleswig-Holstein in Kiel, with expertise in cardiovascular MR and further special interest in pediatric cardiomyopathy. She is the chair of the Association of European Pediatric and Congenital Cardiology Imaging Working Group, and was also a member of the Pediatric and Congenital Heart Disease Executive Committee of the SCMR. Dr. Voges is highly involved in clinical research in the field of congenital heart disease and cardiovascular MR imaging. And we'll also have the privilege to have Tiffany Chen, who is an associate professor of medicine at the University of Washington. She is an interventional echocardiographer and multimodality imager with a clinical and research focus in 3D echo, cardiac CT, cardiac MRI for valvular heart disease. She completed her medicine residence at the prestigious Brown University, cardiology fellowship at the University of Washington, and advanced imaging fellowship at the University of Pennsylvania. She is a member of the writing committee for the Advanced Training Statement on Cardiovascular Imaging, and she has served in several leadership roles for the SCCT and other societies. With that, I would like to remind everyone that each presenter will have 5 minutes to present, so we'll be able to allocate at least 12 minutes for discussion in each case. Questions can be sent using the chat tool, or directly over the mic using the Zoom meeting. Now I'll pass the voice to my colleague, Dr. Renee Bullock-Palmer, to introduce and moderate the first case. Renee, the mic is yours.
Great, thanks, Otavio, and welcome everyone, and happy that you have joined our second webinar. So our first case will be presented by Dr. Sperry, who is a cardiologist and multimodality imager at the St. Luke's Mid-America Heart Institute. He has a subspecialty in advanced heart failure, transplantation, and mechanical circulatory support. He's an associate professor of medicine at the University of Missouri in Kansas City, and he has extreme specialization in amyloidosis and also other infiltrative cardiomyopathy. So today he will be presenting our first case as titled The Complete Resolution of Technetium Pyrophosphate Uptake After Treatment of Transthyretin Cardiac Amyloidosis. Brett, the mic is yours.
Great. Thanks, Renee, and thanks to the other organizers for letting me present this case, just making sure you guys can hear me and see my slides and everything like that. Great. All right, so as was mentioned, this was published last month or a couple months ago in Circulation Imaging. This is the title. Here are my disclosures. So this is a gentleman that I follow. He's 68 years old. He had a 1-year history of increasing dyspnea and low extremity edema. He was found to have atrial fibrillation, was started on beta blocker and anticoagulation. Upon further investigation, we found that his LV walls were thickened and he had features of potential amyloidosis, infiltrative cardiomyopathy on his echo that led to a cardiac MRI, which you see the images here. I've labeled these at the time of diagnosis because we'll see what happens over time and with treatment on some of his imaging findings, but you see fairly classic findings here of cardiac amyloidosis with increased LV wall thickness, biatrial enlargement, diffuse subendocardial LGE down here in the second panel in panel B. So he had testing for a plasma cell disorder. It's very important to do to make sure someone doesn't have AL amyloidosis. Those were all negative. He had a technetium pyrophosphate scan, which was positive, showing diffuse radiotracer uptake in the myocardium on the SPECT images here. We did this study at both 1 and 3 hours. At this point in our lab, we're just doing it at 1 hour, but this was at a time when we were doing correlation studies between 1 and 3 hours. And so this is what his 1 hour and his 3 hour images look like. We can calculate this cardiac pyrophosphate activity, which has to do, the equation here is on the bottom, which has to do with the volume of inflamed myocardium. And incorporating into the volume, you also incorporate the SUV on the SPECT images here, having to do with the inflamed myocardium over the background SUV. And so you see those values there. At 1 hour, this was 414, and at 3 hours, it was 276. But this is more of a research tool. What we really see here is just that the study is clearly positive. The patient had a T60A mutation, considered consistent with hereditary ATTR cardiac amyloidosis. He was NYHA class 3, NT-proBNP was 1860. So this was at baseline. He had chronotropic incompetence and a left bundle branch block, and so actually got a biventricular pacemaker placed. He was started on tafamidis 61 milligrams daily. 2 years later, he was also started on patisiran for polyneuropathy. And so 3 years into his treatment with stabilizer and around 1 year with silencer, at that point he had improved symptomatically. He was NYHA class 2. His NT-proBNP had decreased. We did a repeat technetium pyrophosphate scan, and this was this was about a couple months after the patient had COVID, and he actually had lung findings consistent with fairly severe COVID and had some rib fractures, and so he had from coughing, and so he had some hot radiotracer uptake in the rib fractures areas, which you don't really see here, but on the study you have a 1 hour study here that's positive, but with more faint uptake compared to the diagnosis study up top. And this cardiac pyrophosphate activity, which you calculate was 227. He had a 3-hour study, and this was actually a negative study. There's nothing going on here on the SPECT images, and we do the activity here, and this is 0. So, he is very interested in research, this patient, and understanding what's going on with his disease process. We actually did a follow-up cardiac MRI, which showed fairly similar findings. You see the images there on the left in panel A and B, and then in the middle here on C and D is after 3.5 years of stabilizer and 1.5 years of silencer. At this point, another 6 months go by, NT-proBNP is down just slightly, NYHA is still 2, no heart failure hospitalizations over this period of time, 3.5 years. He had another PYP study done here at this point, and we read both of these studies as negative. The pyrophosphate activity was 0 in both of these, and he had resolution of the rib fracture at that point, as well as the lung findings of the COVID. So we thought it was maybe more of an apples to apples comparison to the first study. So that was the case, the discussion that we put forth, and a lot of potential things to think about and talk about here in this case, and a lot of unknowns. But we have a patient who is on combination therapy with a TTR protein stabilizer and gene silencer, who had an improvement in clinical symptoms and NT-proBNP. So those are good things. Concomitantly had resolution of technetium pyrophosphate radiotracer uptake in the myocardium. So we put the resolution here of this is possible, but the patient had fairly similar cardiac MRI findings, and so you may have unchanged findings. And of course, these things are probably, these two imaging modalities are probably measuring different things. This reduction in complete resolution of PYP in the myocardium raises questions about the fundamental mechanism of bone-avid radiotracer binding in patients with cardiac amyloidosis. Why is it actually binding in ATTR versus AL, and in some types of ATTR, it doesn't seem to bind. Bone-avid radiotracer may wash out of the myocardium more quickly than previously described, particularly in patients who are treated. We saw that in the second time period imaging study, where at the 1 hour, this study was positive, and then at the 3 hours, actually negative. So there may be a washout here that we don't fully understand yet. And the ideal, I concluded this by saying the ideal imaging protocol for the diagnosis of ATTR cardiac amyloidosis may not actually be the ideal protocol when assessing the response to therapy. And this is just a hypothesis that obviously needs more data and more investigation. So that's the study and the case, and I'll open it up to questions and discussion.
Great, thank you. Very nice case. So I'll actually, Dr. Suman, who's in the audience, had a very nice comment. He was very impressed by the case, and he was curious about the 3-year scan time, that there seems to be complete washout of the tracer from the myocardium and not the blood pool between 1 and 3 hours. And I think that's something you alluded to in the discussion section of the paper. Any further comments on that?
Yeah, I mean, I think this is a challenge when we talk about blood pool, and I'll say that I think this, it's a lot of this is related to scaling, right? At 3 hours, you usually have a hot bone uptake, and so the images are kind of scaled to that, and then so you see a lot lower uptake in the blood pool. And so in the second set of images here, this gentleman, you don't see it on here, but had an extremely hot area of rib fracture. And that had really the highest counts and the highest SUVs. And so everything was really scaling to that. And so I think that ends up dropping what some of the other visual images look like. And that's why I think quantitatively it's helpful to do CPA or other types of quantitative measures on SPECT. These are all still in the research realm right now, but I think in the last images here, yes, you see more avidity or sort of blotching of counts here in the blood pool, but you don't see anything that looks like the heart. And in some of these, you see this better on when you use the grayscale images, but you see kind of the negative donut of the heart, what that the myocardium looks like, and then you see the blood pool a little bit more easily when you look at the black and white images. But yes, that's a great comment.
Right. So I think Dr. Bourque, I'll pose the first question to you, since being co-chair of the amyloid guidelines. So in those those set of guidelines, they suggested that with pyrophosphate imaging may be used to diagnose the disease, but not useful in following response to treatment. So what are your thoughts on this case?
So Brett, congratulations. That's really a fantastic case. And I think you bring up a lot of important things here. And Renee, thanks for the question. So definitely when we put the multi-societal consensus statement together, we were really predominantly looking at qualitative approaches and trying to optimize the way that folks would make the diagnosis. And I think there's sort of several things that your case brings up. One is the benefit of using CT, SPECT-CT, compared to SPECT alone. It allows you to do 1 hour imaging and more definitively determine that the tracer uptake is in the myocardium. So I think that is important. I think it's really interesting that your case here shows that your 1 hour imaging had an improved ability to show changes in therapy, in that your 3 hour was to 0 with the first repeat time point. And so you lose that precision in being able to assess. On the other hand, we know that, and we've recommended that 3 hours is generally best if you don't have SPECT-CT, if you're not as experienced a lab. So I think there's definitely going to have to be some sort of honing of exactly what the optimal protocol might look like. And that may be different for labs that are qualitative versus quantitative, SPECT-CT versus just SPECT alone. So I thought that was really interesting. And I think this is a really nice example of use of quantitative techniques with SPECT. And there's a lot of interest in using PET tracers these days because of the unique quantitative benefits that are provided using tools such as flutamidamol or florbetapir. But I think you show a really nice example where you get good results using SPECT. And I guess I'd be curious to see if you've had similar results from other cases and how challenging that's been for you.
So just before we go to that question, I want to include Dr. Dispenzieri in the conversation as well, since she was also an author on the guidelines. So any thoughts on this case, Dr. Dispenzieri?
Am I? Yeah, I'm unmuted. Yeah, I think it does bring up a really good question about what imaging is going to be best, and the limitations of PYP or technetium scanning. I think the other thing that one has to sort of throw into the mix is also, what is the winner? There's so many competing things, whether it's other peptides, the ATL1 or the florbetapin or the florbetapir, or is it going to be a PYP-based technetium scan or a DPD? But the other is, and it was brought up, the MRI. Where does that fit in? Where does the NT-proBNP fit in? Where does strain fit in, or other kinds of markers? So there's a lot of work and interest, and it's a great case. I mean, I can't say I've seen something like this, so I think it brings up just really great questions. I would also just add there have been serial studies, but again, techniques are different, where it doesn't pan out, when you look at numbers of patients where you're not necessarily consistently seeing these kinds of changes. So I think, but the technique piece, like when you're doing the scanning and so forth, may have a lot of bearing in it.
Right, great. So Brett, we have two questions focused on MRI. So question from Otavio, he was wondering if you had the opportunity to quantify T1 by CMR with T1 mapping before and after treatment. And the second question from Jamieson was he was wondering about using extracellular volume on CMR. Did you use that? And then once you answer those questions, you could just tie the findings together before we move on to the next case.
Sure. Yes, I really wish we had this available on both studies, but unfortunately we just had the mapping capabilities on our camera on the second study. So, you know, we weren't able to compare ECV and T1 relaxation times before and after. Obviously, that's another really important thing to follow as we're talking about imaging, and which imaging modality ends up winning, or is it complementary? I mean, I think ultimately these are sort of measuring different things. And you know, it would have been great to have that, but we didn't have that on our initial study, so we weren't able to look from start to finish. But yeah, I just you know, I thought this was a really interesting case. To Dr. Bourque's question earlier, I don't have other cases like this where I've scanned patients serially. You know, as he mentioned in the guidelines, I think it's in there as appropriate if there's a worsening or a change in clinical status, but not necessarily to follow patients. And you know, this is an area of future research for our lab to look at this. And I think while there is a lot of interest in the F18 or the florbetapir and the florbetaben and other types of PET tracers, you know, I think there is more that we can do with PYP as far as scanning algorithms potentially and protocols that may be able to get us some good information on how to follow it as a surrogate marker.
Thank you so much. All right, so we'll move on to that was a very interesting case, and thanks, Dr. Sperry, for that great presentation. So we have our second case that will be presented by two presenters, Dr. Samuel Maidman, who's a third-year medical resident at NYU, and he's an incoming cardiology fellow at Mount Sinai Hospital in New York City. And then we have Dr. Muhamed Saric, who is the director of non-invasive cardiology. He's also the professor of medicine at NYU Langone Medical Center. And he has primary interest in 3D echo and percutaneous repairs with structural heart disease intervention. So they'll be presenting a very interesting case on isolated left ventricular apical hypoplasia, a very rare congenital anomaly characterized by multimodality imaging and invasive testing. So the floor is yours.
Great, thank you so much. So we're presenting a case that was published recently. So just getting into it, the case was of a 58-year-old man who came in originally with symptomatic bradycardia. His past medical history was notable for being told that as a child he had an abnormally rotated heart, but was otherwise unremarkable. He did, about 10 years prior to this index presentation, undergo cardiac MRI based on reporting this to his primary care doctor, and that was reportedly normal, actually. And then with this index presentation, he came in being or having regular bradycardia, but was also otherwise had an unremarkable exam. This is EKG, which was notable for sinus bradycardia, low QRS voltage, poor R wave progression, and a mild interventricular conduction delay. So this is original transthoracic echocardiography. You'll note that there is this spherical LV with a wraparound RV. This is the apical four-chamber view, which again redemonstrates the spherical LV and the wraparound RV. He then underwent TEE, which showed the wraparound RV and the spherical LV, as well as only mild MR. Another view from the TEE demonstrates a dysplastic MV apparatus. This is from his cardiac MRI. So three views of that. This axial cut originally demonstrated the wraparound RV. The sagittal view again demonstrates that And then this transverse short chamber view displays the dysplastic mitral valve apparatus. So these views were demonstrated and were actually a part of one of the figures in the paper. And then additional components of the figure showed there's a 2-2 weighted transverse short axis, which demonstrated fatty infiltration within the myocardium, as well as within the pericardium. And then there was delayed contrast enhanced images, which showed extensive subendocardial LG, as well as evidence of myocardial, which was indicative of myocardial fibrosis in the septum. So to kind of summarize all the findings, which is the characteristic features of isolated LV apical hypoplasia. First, within the LV is a truncated, spherical, and dysfunctional LV with this intraventricular septum bulging into the RV. For the RV, and the elongated RV, which wraps around a deficient LV apex. The mitral valve apparatus is dysplastic with a complex papillary network in a flattened anterior apex, in the flattened anterior apex. And then there's fatty material infiltrating, usually within or near the LV apex. And this was actually first reported only a little less than 20 years ago. Now time for discussion.
Well, Dr. Saric, did you have any discussion points to add here? You're muted.
Sam, thank you very much for a really nice presentation. This is truly a unique case. And once you see it, you recognize it. But until you're really aware of possibility of this, it's really shows how challenging it is. He has gone the patient has gone about 20 years from different physicians, and the diagnosis was never recognized. And this really shows the power of multimodality imaging. Here we are in echocardiography lab. We studied echocardiography, and through work in a structural heart disease, we recognize both the strengths of echocardiography and their limitations. And then here nicely shows out that they're working together with the transthoracic, transesophageal echocardiography, MRI, EKG, and even cardiac catheterization. We didn't have a chance to show that cardiac catheterization and his coronary abnormalities, you can really come up to this diagnosis. And we're also a little bit blessed but the original paper, Dr. Barbara Srichai, was actually at that time, around that time, she was at NYU. She was an exceptional imager and help us with this, recognizing this is really, and we very little know about this disorder. We can just recognize it, what its genetics, what its intrauterine development, and what to do, and the treatment is truly unknown. So this is a rare case. Multimodality imaging can recognize it. Once you recognize its pattern recognition, you will always establish the correct diagnosis of this rare condition.
Great, thank you. So Dr. Voges, I know you being the congenital expert on our panel, would you consider this on the spectrum of left heart hypoplasia, on probably a milder version of that in terms of this presentation?
So thank you for inviting me. This is a really interesting case. And as the previous speaker said, this highlights also the possibilities we have with multimodality imaging. So I'm not completely sure about, because this patient is relatively old, so we do not know what happened since birth. But for sure, the left ventricle is looks a little bit smallish. I was wondering if it is kind of smaller than the right ventricle. But secondly, I also recognized features of cardiomyopathies, So I was actually wondering if this is not a disease that fits into the restrictive cardiomyopathy pattern, like endomyocardial fibrosis. We have similar cases where the left ventricular apex is missing, and this could be included into the discussion.
So I think in the paper, Dr. Maidman and Dr. Saric, you had mentioned the coronary arteries, that they were quite distinctive. If you could just go over what those findings were for this patient.
Sam, take it away.
Yeah, so the coronary arteries were notable for that. It was actually a wraparound LAD. So that was actually one of the things, you know, when Dr. Saric was referencing before, really an unknown and etiology of this condition. The thought that it's the coronary arteries also, and that the anatomy is just strange, may lead to the etiology itself.
Yeah, if I remember correctly, I mean, this is the patient has a very unusual coronary anatomy. He had a super dominant left circumflex artery with the large PDA that it was wrapped around about the apex, which is the opposite of what you would require. So only a minority of people have left circ dominance, but he had the super dominant. And we don't know whether this is that abnormality in the coronary led to the myocardial abnormality, or the myocardial abnormality was somehow triggering abnormal development of the coronary tree. So it's truly a very rare disorder. I mean, Sam, you remember how many we reviewed the literature? I mean, maybe only half a dozen cases that have been reported thus far. But maybe now with the pattern recognition, we will be seeing more and more. Might have been gone previously as some forms of left ventricular cardiomyopathy, but it's a truly unique pattern that we have never seen with anything else otherwise.
So on the MRI, you had showed the fibrosis or the fatty infiltration. It was more in the middle of the myocardium, which I think is classic for a non-ischemic cause of, you know, because with ischemia, you'd expect it's subendocardial. So is it another area that you would look at as a diagnostic criteria?
Yeah, I mean, that was from the very beginning. That was one of the 4 criteria, as Sam nicely pointed out in the very original paper, which was based on CT and MRI, is the fatty infiltration was one of the 4 key elements in the syndrome.
And is there any special predominance for males versus females? What's the typical age that these patients may present?
So Sam, would you like to take the way? And you can mention also the study that it's being enrolled, the Italian study for the genetics about the disease.
Yeah, I don't recall there being any sort of sex-based or any association with that. As Dr. Saric is referencing, there is this Italian genetic study that they're trying to really create a database and then collect genetic material to hopefully find some sort of correlation between any sort of irregularities. But I don't think there's any sort of sex-based association. Age, I think, as Dr. Saric is pointing out, it's frequently misdiagnosed, and I think a lot of this is just raising awareness as this is a clinical entity. And the question is when is it first presenting symptomatically versus just having the right person who's seen it look at the imaging and then point it out.
And I just want to say that the MRI that was originally the MRI, we have the original MRI 10 years ago that was read as normal. So that was really not normal. It was just not recognized as abnormality. So it's not that sort of 10 years ago, he sort of had a normal MRI and then he had some acquired condition, but it was really, it appears that it's really has had, and also that he had from childhood said that he has abnormally oriented heart tells that it's from very early on, he has had this abnormality.
The natural history with these patients, do these patients tend to have a higher risk of sudden cardiac death? It's almost like an arrhythmogenic right ventricular cardiomyopathy. I think Tiffany is mentioning, Dr. Chen is mentioning that, you know, if that could be a proposed mechanism for the arrhythmia for these patients.
It's absolutely possible, but just to give a sense of scope, if you look at that link to the Italian study, how many patients they are hoping to enroll, this is 20 or 30 patients, Sam, do you recall? Is that 20 or 30? It's a very small amount. It's really very, very difficult to base any assumptions. So the patient will be followed in our adult congenital heart disease clinic, and we will have some, thus far seems to have had a relatively benign course. Whether that will be the case, we don't know.
And are most of these cases found in, is there a higher predominance? Well, it's sort of hard to say because it's so rare, but is it higher in Italy? Because I'm thinking of ARVC being one of the high, you know, more prevalent in Italy.
Yeah.
You're wondering if there's a connection.
Might be. It's really that you're absolutely right, that they really those have registry, genetic registry, and this one is in Italy. So it might be, but simply don't know. It simply don't know, and simply don't know how much this is underreported as a condition. Maybe this might be much more common that we know. I can tell you this, I remember the first day that I would thought about Takotsubo cardiomyopathy when I did the conference on the first time, and all of us in the audience, look, what is Takotsubo? We didn't know that maybe 20, 30 years ago, and now everybody recognizes almost on a daily basis. So maybe this will be something like that.
And is there any particular genetic testing that we can send these patients for if we suspect this diagnosis?
I guess that's why the registry in Italy is developed to see are there any markers. But as you know, as the genetics often is really same gene might account for hypertrophic cardiomyopathy or hypertrabeculation in the apex, and I simply don't know. Sam, did you read any other literature that?
Yeah, I think it's just so rare that there isn't much that has linked it to anything. I think also notably, I think there was a question before about just how these patients present, and a lot of it, I mean, this patient came in with symptomatic bradycardia, but I do know that when we were going through the literature of those only a handful of cases, I believe there was 1 or 2 patients who did come in with ventricular tachycardia, and I think even one of them passed away from that. So that also regarding other conditions that are related to it.
Well, very interesting case. And I think we have a lot more to learn in this space. So Otavio, I'm going to turn things over to you.
Okay, thank you, Renee. And now we moving with our program here. We have our 3rd case of the webinar, which is also a fascinating case. The title of the case is A New Approach to Assessing Heart Damage and Inflammation after a heart attack using hybrid somatostatin receptor positron emission tomography and magnet resonance. This case will be presented by Dr. Jason Tarkin, who is a Wellcome Career Development Fellow and an honorary consultant cardiology with an imaging subspecialty at the University of Cambridge. He is also a junior research fellow at the St. Catherine's College in Cambridge as well, and a research co-lead for the British Society of Cardiovascular Imaging and British Society of Cardiac CT Committee. Dr. Tarkin, you have 5 minutes to present your case. Following that, I would like to invite Professors Bourque, Chen, and Voges to discuss your case. Tarkin, the mic is yours. Go ahead.
Great. Well, thanks very much for that really nice introduction and for the invitation to speak today. So this is a case of a 36-year-old man who presented with acute chest pain. He didn't have any traditional cardiovascular risk factors. His examination was normal. He had evolving inferior ST segment elevation, and so was taken to the primary angioplasty center. And he had the coronary angiogram, as you can see here, very minimal disease in the right coronary artery and the left anterior descending artery, but an occluded obtuse marginal branch of the left circumflex. So he underwent primary PCI to this vessel. He was treated with usual preventative therapies after myocardial infarction. And you can see here his blood results showed that his cholesterol was abnormal and his troponin was significantly elevated. So this patient was enrolled in an ongoing research study that we're undertaking at the University of Cambridge. This study is being conducted by one of my PhD fellows, Andrei Korovic, who's shown here in the picture. So as part of the study, the patient underwent serial PET MR imaging with a tracer called gallium dotatate, which is a clinically available somatostatin receptor tracer used for neuroendocrine tumor imaging, but we're repurposing it for imaging inflammation. He also underwent cardiac MRI and CT coronary angiography as part of the study. And in parallel, he had serial blood tests taken for deep immunophenotyping. So just quickly covered the rationale for using this tracer. So we and others have shown that the somatostatin receptor 2 is expressed by activated macrophages within atherosclerotic plaques. As I mentioned, it's a clinically available tracer, and when repurposed, we found that it can provide a marker of inflammation within coronary arteries, carotid arteries, and it can also highlight the infarct zone in patients with myocardial infarction. And more recently, we've shown that in vasculitis as well, subclinical myocarditis can be detected, as shown in this case here. So getting back to our case, the MRI scan showed overall preserved LV function in keeping with his transthoracic echocardiogram, and regional wall motion abnormalities in keeping with a left circumflex territory myocardial infarction. I'll just leave that to play for a second. Just to mention, these images were taken post-gadolinium just due to the research protocol on our PET MR scanning. And then on T2-weighted imaging, you can see that there's myocardial edema and corresponding segments in the basal anterolateral, mid-infralateral, and apical lateral segments, with again corresponding near full thickness and subendocardial myocardial fibrosis in the same affected segments. Here are some representative images of the PET MRI scan from the case, where you can see there's clear uptake of the gallium dotatate tracer, co-localizing with the infarct zone highlighted here by late gadolinium enhancement MRI, and very low signal in the remote myocardium. So we next wanted to know how the signal changes with time, and you can see here on the top the baseline scan performed after 11 days, and on the bottom the 3-month PET MRI scan, and you can see that there's resolution of the myocardial edema visually on the MRI, and there's also improvement in the PET signal. You can see that the PET signal is tracking resolving inflammation, both as shown by the MRI and also the biochemical markers here. You can see the resolution of the troponin, the BNP, the inflammatory markers, CRP, IL-6, TNF-alpha, etc. But there appears to be a very faint residual signal in the infarct, which wasn't overtly evident on the MRI scan. And then lastly, this is the 1-year scan, which wasn't shown in the publication, but you can see here that there's some improvement in overall left ventricular function, but there are persistent regional wall motion abnormalities in the scarred territories. So in conclusion, this case report is a representative example from our ongoing study that highlights a newly emerging molecular imaging method to highlight specific components of the immune response following myocardial infarction. The ongoing study will characterize the cellular and molecular origin of the PET signal within the infarct zone, as well as the coronary arteries. And it will also examine relationships between long-term myocardial remodeling and viability. And in the future, approaches such as this could be useful for informing the clinical use of emerging immunomodulatory therapies. Thanks very much.
Thank you, Dr. Tarkin, for the great case and the outstanding presentation. Now this case is open for discussion. I wonder if any of the specialists here in nuclear and molecular imaging want to comment. Probably Professor Bourque, do you have any comments related to this case?
I do. So, Dr. Tarkin, thank you for a fantastic case. I think this is a really interesting example of the power of multimodality imaging, the ability to take advantage of the unique strengths of each of the modalities and put them together and provide better information than we could with one alone. I think it's fascinating. You take advantage of the high spatial resolution and excellent scar mapping with CMR to be able to very precisely localize where there would be issues, and then using nuclear imaging for to be able to target specific physiologic processes. Here you've very nicely shown the application of dotatate, which repurposed from a different organ system entirely. And so I thought that was very interesting. And in particular, the strengths of nuclear in having very high sensitivity So I think here you have a case where there's a very robust response, but I think one of the strengths in nuclear would be that you could have coaxed a signal out of even a much smaller, less in cases that were more borderline than this, you'd be able to still discern a pattern. So I think this is a really nice example of those together. And I think it'll be very interesting moving forward, as we saw in our first case, the ability to do quantitative techniques to look over time. You know, I think that, and you showed some data with this, I think is a very powerful potential application. So nice job.
Thank you, Dr. Bourque, for the nice comment. And anyone else want to comment? Dr. Tarkin, I have one question, and one of the things that really puzzled me was the age of that patient, right? Was 36 without prior history of any risk factors for cardiovascular disease. Any clue why this patient really had a acute myocardial infarction? Did you investigate, for example, any genetic disorders or things like that?
Yeah, so really important question. Thanks for answering. Thanks for asking. Yeah, of course, that was striking to us as well. You know, it's unusual to have patients present at this age with atherosclerosis in acute events, but of course it can happen. We didn't find anything unusual in the appearances of the invasive cath or the subsequent imaging to suggest something like a dissection or a thrombosis or anything like that. He did have, mildly elevated lipids. He did have a little bit of plaque in his other arteries. So he was treated aggressively for atherosclerosis, and there was nothing else that we found in terms of his past history. There was no drug abuse. There's no strong family history. There was nothing really else to point to an alternative cause. Of course, as part of the research study, we're doing, deep immune profiling, proteomic inflammatory markers, transcriptomics, and it may well be that we find something interesting in this case that stands out, but at the moment we don't have that information. But yeah, it's really interesting to us as well as to why this patient presented so young, but I guess it just goes to show how the disease is changing and unfortunately, affecting younger people.
Thank you. So now I want to ask Dr. Chen if she has any comments on the CMR images. The T2 was quite, I would say, remarkable, was pretty positive, and also showed that during the follow-up, the edema also decreased. Do you have any comment on that?
Yeah, thanks. This was a great case and great demonstration of a new technique marrying the nuclear techniques with CMR. I think one of the issues that sometimes we encounter with T2 mapping is it's oftentimes not as nice as how you show here. You had a patient with a transmural infarct with a large event. And so it's very obvious the T2 increase, but oftentimes we're a little bit in a gray zone. And I think in patients, obviously with ICD or pacemakers, very difficult for us to do T2 mapping, even if we can get LGE imaging by CMR. So I think using this technique to detect inflammation and track it over time offers some value beyond the CMR in this case, or in cases like that. I was wondering, actually, we spoke about how this was a transmural, how does this perform with a non-transmural infarct, subendocardial infarction, and also in cases, non-ischemic cases where you may have inflammation, such as with sarcoid and myocarditis. I imagine the signal would be more diffuse, and how does that perform compared to CMR, or what have you learned with that?
Yeah, absolutely. Thanks again for a really nice question. So I guess the first thing to say is coming back to the spectrum of the severity of myocardial infarction, which was touched on earlier as well. So this is a study. We've enrolled 40 patients here. There's also a parallel study in Italy where we've enrolled another 40 patients. And there is a large spectrum of severity of infarcts. And what I can tell you from what I've seen is that even in patients with, troponins on our scale of 400 and very minimal subendocardial scar, there's still a signal in the infarct. And what that means is something that we're trying to understand in terms of, longer term outcomes, but there certainly still is a signal. And I think that is a strength that you pointed out with PET, which, you can detect much more sensitive signals than perhaps with MRI. Again, this was a case where there was overt edema on the MRI imaging. Some cases there have been less intense imaging, but we've actually been surprised with the MRI scans that actually a lot of these patients with big infarcts still do have edema at 3 months, which we weren't really expecting to see. And then, so getting back to your question about other conditions, so sure, other groups have looked at sarcoidosis, so the Harvard group and other places have looked at sarcoidosis, and they've seen some interesting results. We've done a study in large vessel vasculitis, and anecdotally, a few patients had, myocarditis, which I showed in one of the slides. So I do think that, yes, there's still inflammatory signal there. It co-localizes very nicely with FDG, but it's telling about a slightly different process. And I think there's still a lot to be learned about clinically how this might be able to be used in conditions such as myocarditis or sarcoidosis. Certainly, it has less of a direct clinical application in ischemic heart disease, but still really useful in the research setting. So yeah, that's where we are.
Thank you, Dr. Tarkin. We are almost reaching our, time limit here, but I think we still have time for a couple more questions. Have you think about trying, this technique to investigate plaques? Perhaps you could use, this technique to identify vulnerable plaques. Do you think that you have enough resolution to use your molecular technique to identify that?
Yeah, so this is where we sort of began with this tracer. So we showed in the initial publication that, yes, you can see very nice signals in coronary plaques. And actually, the primary outcome of the study that I described is looking at plaque progression in non-culprit arteries and how that relates to coronary inflammation. This was just a nice example of the signal in the infarction, because it wasn't something that we had previously published. And I think really highlights the benefits of PET MRI imaging, as we've heard, with the complementary information between the MRI characterization and the PET imaging. But certainly in this study, and particularly with our collaborators at the University of Bologna, we're looking at, OCT compared to coronary signals, and yes, I think is the answer. I mean, you need careful motion correction, obviously, for cardiac and respiratory motion, but it gives a nice signal with low background that allows you to image the coronary arteries.
Great. And in terms of, I would say, practical terms, in terms of implementation, right? Very few sites worldwide will have like a dedicated MR and PET system, right? So in terms of implementation, how long will it take, for example, to do one case? Because an MRI study usually takes like 40 minutes, eventually 35 minutes then. So what is the time that you usually spend to do one case?
Sure. I mean, it all depends on what you're looking to achieve, and certainly the scan can be shortened depending on what you're looking for. But these research cases, we're really trying to get as much as we can out of both the MRI and the PET data, so they are long scans. The PET bed is 35 minutes, but the MRI extends a bit longer, up to an hour. It doesn't need to be as long if you have a more focused question, but we're trying to get as much data as we can. And also performing CT angiograms to look at the coronaries, which again you wouldn't do in a clinical patient who's just had an invasive cath.
Thank you, Dr. Tarkin. So with that, I think that we are reaching the end of this webinar. I would like again to thank you all the attendees. Thank you the panelists for finding time in their schedules to be here with us. Thank you also the presenters for the nice cases and the great presentations. I think that we had here a great opportunity to discuss very, I would say, fascinating cases with a group of specialists. With that, I again thank you everyone for being here. I will ask Renee for her, last comments, and thank you again for being here with us today.
Yeah, just like the second Otavio's comments, thanks again. The cases were really amazing and the discussions were great. Thanks. Right. Okay, thanks.
Thank you.
Take care, right?
Bye.
Bye-bye.